So good afternoon to our friends and colleagues on the East Coast. Good morning still to our friends and colleagues on the West Coast. And thank you so much for joining us today. We are excited to be gathering with our esteemed panelists to discuss the state of healthcare and healthcare administration in prisons and jails across the United States. My name is Caitlin Flood, and I am the Director of Release Reform Initiatives here at the Center for Justice and Human Dignity. And a little bit about our organization before we dive into the content. We at the Center for Justice and Human Dignity focus on foregrounding human dignity in the administration of justice by addressing conditions inside jails and prisons. And we do so by focusing on work that is informed by the lived experience and expertise of currently and formerly incarcerated individuals, as well as correctional leaders and staff, advocates, and health experts. We're addressing ways to advance and enhance release reforms for those serving sentences and lengthy sentences and short sentences with fewer opportunities for sentencing review, really with an eye towards second chances, second looks, and opportunities to rethink lengthy sentences that could be readdressed by practitioners and experts in the field. So we're excited to get started, and I wanted to just start with a few housekeeping items so that everybody knows kind of the format of today's panel discussion and how you'll be able to access or share out this content in the days and weeks to come. So we invite everyone who's joining us today to put any thoughts you might have in the chat box, which you should be able to find either by hovering at the top of your Zoom screen or the bottom of your Zoom screen. And we'd also encourage and invite you all to type in your name and organization that you're affiliated with or your jurisdiction, so that we can have a better idea of who is joining with us today. And then throughout the panel discussion, I'll be keeping track of any questions, either that come in through the chat box, or we would encourage everyone that if you have a question that you would like answered at the end of our panel discussion, we'll be doing a more structured Q&A for the panelists. And we would love for any questions, concerns, comments, feedback that might come to mind. Feel free to throw those in the Q&A box, which again, you can find either by hovering at the top or bottom of your screen. And we'll make sure to kind of direct those questions to the relevant speakers at the end. So feel free to write those questions in. And if you're having any tech glitches at all, please feel free just to put a note in the chat, and I will work on helping you figure out those tech glitches. And we are also joined by Chandra Williams, our wonderful, fearless, and very, very tech competent, more so than me, executive assistant. So I think without further ado, I'm going to turn it over to our wonderful colleague, Eloise Caney, who's going to start us off with a bit of context for our discussion today, and then dive right into the substance with our great speakers. So thanks so much, everybody, for joining.
Yes, thank you all so much for being here. And thank you, Caitlin. My name is Eloise Caney. I am the program manager here at the center, and I'm really honored to be joined today by three experts in the healthcare and public health fields. So we have Dr. Bruce Herdman, who is Chief of Medical Operations at the Philadelphia Department of Prisons. Next, we're joined by Jennifer Grossman, a longtime registered professional nurse and founder and executive director of Nurses for Social Justice. And lastly, but absolutely not least, we have the wonderful Dr. Dana Rice, who's Associate Dean of Master's Programs and Associate Professor within the Public Health Leadership Program at UNC's Gillings School of Public Health. So thank you all again so much for being here with us today. We're really excited to dive into the content. So today we're here to discuss healthcare in prison. People in prisons and jails are disproportionately likely to have an array of chronic health problems, diabetes, high blood pressure, HIV, not to mention substance abuse and mental health problems. Quality healthcare in prison and jails can be extremely difficult to access and has really proved to be an even more urgent challenge during the COVID-19 pandemic. So the danger presented to prisoners was not only the virus in close quarters, but really showed how underlying conditions, chronic comorbidities present for years could really be lethal when combined with this virus, and has really turned increasing attention to how people imprisoned and in custody are cared for. So today, we really hope to reflect on the role of prison healthcare providers, and we'll hear from you all who have provided care or manage the administration of medical services across prison or jail systems. Just a little bit more, and then we'll hear from you, but there really are distinct challenges to providing quality care in these carceral settings. We hope to dive into, really the importance of infrastructure supports like functional data systems, training for providers new to this setting, establishing standards of care. And we really hope to arrive at some changes and suggestions that could be made to improve outcomes. So really, the goal of this webinar is to highlight to judges and to other practitioners and reformers in this space, the current limitations on adequate care in prisons, which can be a relevant factor when determining sentences. And we also really hope to highlight opportunities for judicial reconsideration of sentences in light of changes in health conditions. So with all that said, we'd like to dive in. We'd like to start by posing a question to each of you. We'll start with Dr. Rice, and then Ms. Grossman, and then end with Dr. Herdman. So this is just sort of an introductory question. You each have very diverse backgrounds and areas of practice. So we just kind of would like to know, how did you come to work in this space, specifically dealing with healthcare, health systems, specifically in a correctional setting? So Dr. Rice, if you'd like to respond first.
Happy to do so, and grateful to be here with you all for this conversation. I wish I had a really interesting, sexy story for you all, but I actually fell into this work not by any sort of plans, but I have stayed in this work intentionally throughout the years. So I was working in local public health in Detroit, Michigan, and was actually working in environmental health while working on my master's degree in public health at the time, and actually had more of an interest in working on issues related to infectious diseases. And so, as you just mentioned, this population definitely experiences higher levels of both infectious diseases as well as chronic conditions. And there happened to be a position that came open in our local jails at the time to focus specifically on infection control and infectious disease management, of which I felt, because the goals aligned with my professional goals, I was interested in sort of applying for the job and moving into that setting. And it really wasn't until I got in the setting, of which I had no prior experience in working behind bars, that I realized that the job had been vacant for 8 years. And so there had been very little work done there, which was a good thing and a bad thing professionally for me, because it allowed me the opportunity to really think, design, and build program and structure where it had been lacking and missing. And I mean, that's just an indication of one example of a system that had services that were not being maximized. The services were not having the opportunity to be maximized because there was no one in these roles for extended periods of time. So really, that's how I got into this work. And it is only through my direct work behind bars, of which I ended up spending about 17 years working in the system, where I really started to understand not only how the systems work, but how the policies affected how the systems work, and also gain a really better understanding of the impact of the system on the communities and on the health of populations. And so that's how I ended up staying and have been continuing my work thinking about mass incarceration and thinking about populations who have been behind bars and their health specifically since then. So thank you for having me.
Thank you so much. And we're really excited to hear, more about your experiences and how they've informed your perspective on the space. So appreciate that. Ms. Jen Grossman, we'd love to hear from you.
Thank you. Also really happy to be here with all of you. Before the pandemic, I worked primarily with hospital medical records. So I was working with attorneys on criminal cases But of course, those cases, most had not, made it anywhere near trial. And so I was looking at medical records for shootings and stabbings and general, mayhem on the physical body. But those were hospital records, right? And sometimes maybe some background records from a primary care doctor's office, or maybe some physical therapy records or something like that. But of course, when COVID hit, when it hit New York City, which is where I'm based out of in Brooklyn, there was this crazy scramble. And I know this happened nationally as well. But, everyone that I was working with, specifically criminal defense attorneys and public defenders and assigned counsel, were trying so hard to get as many people out of what basically were these giant congregate living facilities, right? Like, we used that term during COVID, talking about nursing homes and long-term care, but it was like really hesitated to use it for prisons and jails. But it was the same living situation and the same dangers, especially with a really aging population in prisons and jails. So, we didn't have the vaccine yet, and people were dying, and all these attorneys that I worked with over the years reached out. And, at first it was like little bits of medical records from Rikers or a prison in upstate New York, because there wasn't time, right? There wasn't time to get background voluminous records for people that had been incarcerated for a long time. And, that was a scramble. And then the longer this went on, and then actually into us having a vaccine, I was writing these brief reports, and then once we had the vaccine and we weren't able to get as many people out of prisons and jails, I really started, I had a professor and attorney at CUNY who reached out. That's the City University of New York, the kind of like our local community college, but in New York City, it's this giant system, right? And they asked me to work with some of their students on medical release cases. And that, of course, led to contacts in other organizations that do similar work, and then working with clients who are up for parole. And so with all of those clients, all of those incarcerated people, their medical records, spanned decades. And so that is where I really got to see what was going on in these medical records over a period of time, and the actual health of incarcerated people and the health care that they were not receiving over a time period. And of course, very, very disturbing. And it's been, I still do all of the work that I was doing before, where I'm looking at hospital medical records because an alleged crime has been committed, or mental health records to determine cognitive issues. But this has become a really big part of what Nurses for Social Justice has been doing, and what I have been doing, personally, and aside from that. And it doesn't seem like, unfortunately, it doesn't seem like there's really any end to that, because of the vast number of people who are ill and incarcerated.
Okay, thank you so much. Yeah, we're excited to hear more in detail about Nurses for Social Justice in just a bit. So thanks so much. And then finally, Dr. Herdman, can you give us a little bit of background about your expertise and sort of how you got into this specific field of work?
Yes, I have a doctorate in economics from the Wharton School at Penn, and I've served as a hospital administrator and as a senior administrator in Blue Cross in Philadelphia, and then retired to my farm in South Jersey. And I was growing soybeans. Talk about not a sexy transition from soybeans to the prison. Someone called me and asked me if because I'd worked with FQHCs and I was on hospital boards and so forth, if I would help sort out some financial issues at the Philadelphia prison. And I did, even though I lived in Philadelphia for decades, I didn't realize that it had a prison. I didn't know what the difference was between a prison and a jail. So I agreed that I would try to do some help. I thought it would take a couple of months to sort out whatever these, cost issues were. And I've been here 15 years because of the opportunity to serve this very needy population that comes from our most economically and educationally disadvantaged neighborhoods in Philadelphia. It's been a spectacular experience in my career. So that's how I got here.
Okay, that sounds great. And we're, again, excited to hear more about the particular services that you've sort of introduced to your clients and the innovation you brought to the system you work within. So now I really would like to dive into the nitty gritty and taking it back to Dr. Rice. We'd love to hear, if you could walk us through some of your observations about the intersection between a public health framework and mass incarceration, observations through your experience, suggestions for the future. Just would love to hear about that.
Yeah, happy to share a few thoughts. I mean, we could spend hours and days. I teach a class on this for a semester. So there's a lot we could actually dig into as we think about the relationship between how and why mass incarceration is really a public health issue that requires and will require a real interdisciplinary perspective and action to move us to a real different place, right? So for us to imagine some alternatives to what our current system looks like and how it operates. And so what I would say is that, we have quite a bit of documentation around how interaction with the criminal legal system is both sort of a determinant for health outcomes. So interaction with the system, people who interact with the system, as Dr. Herdman just said, come from communities that have been underserved and under-resourced, that really have also been impacted by policies that we've enacted in this country that has resulted in disproportionate numbers of minority populations, Black and Brown communities, Indigenous communities, and poor people really having greater interaction with the criminal legal system. And we also know that this disinvestment in community leads to poor health outcomes. And so really interaction with the system has real significant implications for the health of populations, right? And so what I have been thinking about in my work is really not only documenting what these relationships look like, because we have to be able to measure these differences so that we can start to think about interventions. And I think traditionally we have, oftentimes we have taken a medical model approach, which is really an approach that deals with sort of a single person at a single point in time and trying to address the issues of the individual, sort of like what a doctor does, right? Whereas a public health approach is really about understanding the impact on populations and communities collectively. I think what we have seen in COVID has really introduced people to the world of what public health is all about, and this tension between sort of individual level responses instead of sort of community level responses. And when I talk about mass incarceration's relationship to public health and health outcomes, I'm really talking about those community level responses, those community level policies that we've put into place that then result in community level deleterious outcomes for populations. In public health terminology, we would say that interaction with the system increases mortality and morbidity, which is really just death and disease. And disease runs the gamut from infectious disease to chronic diseases to sort of physical, mental well-being even, right? So not even where we would classify something as a disease, but just well-being and wellness in community. And I think we could all agree that we really want to live in a society that supports wellness and well-being and care. And our system has not been structured in such a way that it does that. And yet we continue to invest in this system, both financially, right? And with our policies that are enacted in ways that actually literally don't make sense. They're not supported by the evidence to show that they reduce crime. They're not supported by the evidence to show that they reduce or improve well-being for the community, or that they make people healthy and well. And so I think if we're going to really be smart about moving forward with a system that actually provides justice for those that have been harmed, we have to rethink our approach to doing that. And so that's kind of what my thought is around why public health must be involved in the conversation around thinking about providing and offering justice. When we get at sort of the details of what that looks like, I mean, there are things that we can do prior to someone entering into the system, which I'd like to think of as sort of primary prevention, right? It's the ways that we protect ourselves from contact with harm. And then there's sort of the secondary prevention approach, which is really improving conditions of confinement, which I think is part of the conversation today when we're talking about improving healthcare delivery and healthcare services for people, for the 2.2 million people who are currently behind bars in jails and prisons. And then we have to really think about the tertiary prevention. So after someone has been through all of these layers of the system, what are we doing to support them as they return to community to make sure that they don't come back into the community, come back into the system? Because we know that as it's currently structured, we've created a system that creates a constant cyclical churn of folks and have made it very hard for people to get back on their feet. And part of that work is work that has to be done in community. That same work that's done in community that supports people staying out is the same work that needs to happen to support people from going in. So the healthier our neighborhoods are, the safer our neighborhoods are, the more we're able to have sidewalks and access to healthy food and access to health care, right? The more we're able to invest in what we call the social determinants of health, the more we're able to divert people from entering into the system in the first place. So that's really how I think about why this is a public health issue. And I think that the more we are collaborative with colleagues who, like judges, like people in the legal profession, like folks who work across the system, the more, and de-silo our practices, I think the better we will serve our communities and be able to really create a system that is just and equitable. So I'll stop there.
Perfect. Thank you, Dr. Rice, very much. That leads us perfectly into sort of my next question, which is going to be geared specifically towards Dr. Herdman. So we'd like to hear specifically how your team, speaking of health equity and de-siloing systems of health administration, we'd like to hear how your team has been able to ensure that people or clients are connected to medical care and just other necessary wraparound community services, both while in custody and soon after, when they are returning to their communities and, you know, potentially lost with no connections, with no resources. I'd like to hear a bit about your experience and how you try to fill that gap.
Surely. When I came here, this place was administered with the traditional correctional view that medical care was only, you just provided what you absolutely had to within the walls, and you didn't care what happened before or after, particularly. Not that the individuals didn't care, but and it was crazy to tune someone up medically or behaviorally and then send them out to the community with no idea where to go, how to pay for the care, and so forth. So this is the jail for the county of Philadelphia, and which is a city of 1.7 million. Probably close to 200,000 people in the city have at some point been convicted of a felony. So Dr. Rice, when you talk about the overlap of this population inside and outside the walls, it's really quite dramatic and it's not visible. And we have 85% of the people in the jail are of color, which doesn't match the mix of color, citizens in the city of Philadelphia. And we have significant chronic illness, 28%, 38% are on a behavioral health caseload, 3 times the normal rate of HIV and hepatitis C and so forth. So let alone, as you said, Eloise, 70% or more who have substance abuse disorders. And then the underlying conditions of reportedly 11 years of education, but a 5th grade reading level. And that's not because of intellectual disability. That's because these 33-year-olds on average either haven't gone to school or went to school and didn't learn much. So their prospects are pretty dim. So what we have to worry about is not hurting people, and then making sure they get what they are constitutionally entitled to. And then secondly, try to link them effectively so that they can continue their care after release. So I'm lucky to work in a city where we have 350 full-time healthcare staff here for a daily population of about 4,500 inmates, which is not characteristic of jurisdictions around the United States, I understand. Our budget for healthcare, and this doesn't include the facility and the officers and the light and water and electricity, is $75 million. So it's a pretty significant investment, entirely, with the exception of about $3 million of city tax dollars. And when we can save money by becoming more efficient, the city allows us to invest in the programs, Eloise, that you're talking about that don't fall under traditional healthcare and really relate to assuring continuity of care on release. So one of the keys here is that we work very closely with the public defender and to a lesser extent with the district attorney and judges. But with the public defender, for example, we provide a daily report of medically vulnerable individuals to help in their in any release that's acceptable to the courts. These are generally very ill people where their families don't have very much access to them when they're in the jail, or if they're hospitalized and guarded by two officers with loaded weapons on their hips. One of the things we also do is we try to evaluate people very quickly, because this is a jail and 40-some% of the people are released within a couple of weeks. So we complete our medical intake evaluations, which is through an electronic health record, and RN administers a 140 questionnaire in 4 hours after the person gets off whatever vehicle leaves them at the jail. And that evaluation automatically generates appointments. So for example, if a person says they're asthmatic and they're symptomatic, they're going to be seen right away. If they say they're asthmatic and they're not symptomatic, the electronic record automatically creates an appointment for the next business day in the chronic care clinic, so that we have standardized care across all of the people that are in the jail. And it doesn't matter if they move from one building to another, those appointments track with them, so that we can assure that everybody gets the care that they need. And then we have a series of evaluation tools that our nurses and physicians use to standardize. They don't have to do exactly what's in these evaluation tools, but it reminds them of what they need to do with all of the varieties of illnesses that they're going to face while a person's in the jail. So for continuity, and let me say, we provide 250,000 visits a year, 250,000 encounters, about 225,000 prescriptions. We have a 64-bed licensed psychiatric facility, which is actually about half of the total number of psychiatric hospital beds that the state has, because and so we're the largest provider of those services in the state of Pennsylvania, the largest provider of psych services, HIV services, Hep C services. We distribute Narcan. We have about 3,000 people a year that we start on Suboxone in our medication-assisted treatment program, plus another 750 that are maintained methadone or Suboxone. And then for continuity, the first thing we faced was that only 8% of the people coming through the front door had medical assistance. Nobody here qualifies virtually for commercial insurance. So only 8% had MA. So we now enroll people in medical assistance. We worked with the governor, and it has tremendous help. And we have about 95% of the people leave here with medical assistance that's effective the day of release, so they can pay for the services that we hope they're going to get when they leave. People didn't know where they could go, so we meet with anybody that has a chronic illness and help them choose a community provider, and we instantly send an electronic referral, secure, HIPAA compliant, to that provider, because our folks could be released within minutes because of the bail system, and hopefully many of them are released right away, because we do have an awful lot of people that shouldn't be in the jail. And then when a person does leave, we send a discharge summary, which is the same as any University of North Carolina hospital, if that's the right term, would send to a person on release. And that goes out electronically to help with continuity. Our next step in that regard is issuing photo IDs, because although the women that come to the jail, because they have responsibility or take responsibility for children, generally have photo IDs, the men do not. And they can show up at a program and the program will say, we'd like to take care of you, but we don't know who you are. So that's one step. And then the larger thing, and I think is the wraparound services. How do people pay for heating, for food, to pay their rent? And so we're trying to work with a nonprofit that's in Philadelphia, though it serves many states, called the Benefit Data Trust, where we would help them, every one of our folks, enroll in the BDT program, which can give people access to 17 different federally and state funded programs, like LIHEAP, for example, or SNAP, to provide the wraparound services that really are required if we want them to go to get medical care. Because if they don't know where they're going to sleep or where their kids are going to get food, medical care is not going to be top on the priority. And we haven't solved that problem at all, but we're working on trying to address that for this population that is so needy. So that's my outline for you.
Wow. Thank you so much, Dr. Herdman, for that level of detail on programming. And I see our other panelists, shaking their heads, agreeing, especially as we sort of talk about this community context. It's almost futile to look at individuals just as medical patients, floating on their own. That's completely not what is going on. And I'm really impressed by this more complete holistic picture of the needs of the individual and how they relate as they're moving back into the communities that they should be able to thrive in. So thank you so much for your answer. And now we'd like to turn to Ms. Jen Grossman and hear a little bit about sort of your background and hear more about the impetus for Nurses for Social Justice, and really how legal practitioners can learn from medical professionals when it comes to the intersection of healthcare provision and legal advocacy.
Yeah, I just want to say, Dr. Herdman, that one of the things that Nurses for Social Justice has really wanted to begin to do is to create kind of this safety net for people who are leaving the prisons or jails and setting them up with someone who can help them deal with the medical system. I mean, leaving, sure. Yeah, leaving, and especially if it's been any real significant amount of time dealing with like the cultural, family, job, parole, like who is going to be taking care of their blood pressure? Like it's the last thing that you're going to care about. So so Nurses for Social Justice, I mean, I could talk about how this started in so many different ways, and really this made me think a bit about from a deeper level. Like usually I'm like, oh, it started when, not a joke, but a public defender walked into a bar. But literally that's actually how my work with attorneys started. But really, I mean, it goes back to how I was raised, right? Like I had a huge Catholic family. And so Mother Teresa and Mary were everywhere in my childhood. And then my mom became a born again Christian, and Jesus was everywhere in my teenage years. And she became a minister when I was a teenager. So it was really like this is the way people are supposed to behave. And there's a lot of, complaints about not walking the talk and all of that, but it was just so important in my upbringing. And then I got to high school and I was like, you guys aren't walking the talk. And I learned about Gandhi and I was like, whoa. And I looked around in high school and there were all these cliques, and there were like, in the lunch cafeteria, there were like what we called the freaks and geeks table, right? And I just like made a beeline. I was like, I'm not into punk rock. I don't care about goth. But like I can't sit over here and make fun of this group. I have to just go be in it. And I really think, I'm not comparing myself to those people, to these amazing icons who have, done amazing things, and who so much behavior is supposed to be based on. I'm just saying, like, their ideals, they really got burned into my brain at a young age. And then, you know, I mean, who can be crueler than a teenager, right? So like in high school, that just really hit me. And I carried that into nursing school and into working at a hospital here in New York City. You know, my first bedside nursing job was really like in a typical hospital setting, like what you normally think of when you think of a nurse. And it wasn't my first career, right? I wasn't like 20 when I started that. I was in my 30s. I'd had a couple of careers already. And so despite the, like, you know, we're a team, we're a family here at this hospital, that kind of lip service, I realized very quickly that no one in that hierarchy of business cared about me. You know, it's corporate healthcare. And I feel like I was really lucky to know that long before COVID hit, because I feel so bad for the people that have worked in hospitals and have had to realize during a pandemic that's just killing people left and right, that their employers don't care about them. And I really feel for them. And so when I was working in that setting, in the hospital setting, well over a decade ago, I saw all of these people come into the hospital who were like the freaks and geeks table, right? But in this case, it's way more detrimental. It's not just, you know, your teenage growing psyche, but like this, we only get one body. You get one body. And if someone messes with it, that's forever. And so I was always the nurse that was like, yeah, that person who's a drug addict that no one else wants to take care of, give them to me. I'll take care of them for the entire time that they're here. Make that my patient. The person who's handcuffed to the bed, you don't want to because you're afraid, they will be my patient. The transgender person that comes in, who all of the nurses on the floor are like, oh, I don't want to take care of that person. I was just like, me, I'll do it. And so, you know, clearly it just, that hadn't changed in my life. And, you know, I was 3 years into working as a bedside nurse and I really wanted out of it. The corporate hierarchy just, I was disgusted by it. And, you know, we were always short-staffed because they were always trying to save money because it's a business, right? And it was dangerous. And I thought I would get into primary care, and I worked outpatient, and I managed a big primary care office in Manhattan connected to Mount Sinai Hospital. And I realized there, after quite a few years, a smart person said to me, just because you're good at something does not mean you should do it. I was like, yeah, getting out of here. And that was when I met this public defender in literally end of March, beginning of April in 2012. Public defender walked into a bar and my husband was the bartender, and he was a regular there, and they just started chatting, and that's how I started reviewing medical records. And we realized, the two of us together, that there was all this information that I had about the healthcare system, not just about medical records, right? Like that's just a part of it, but also knowing the system, knowing that there's way less people available and particular procedures aren't done on weekends and holidays, knowing, you know, what the process is for charting, knowing what the process is for, you know, care plans and who you're supposed to call when something goes wrong, just all of that. We realized that I had all this information, and I started doing free continuing legal education presentations to attorneys, you know, first all over New York City, and then into Connecticut and New Hampshire. And at that time, my husband, who's not just a bartender, but also a musician, of course, he was going on tour. And I was like, I want to go on tour too. So I bought an RV and I started doing CLEs all around the country, free, right? Because when they cost money, sometimes your organization doesn't have the money to pay for them. And so the idea was going to do free CLEs, and then I'll have more business with criminal defense attorneys. And then very quickly I was like, public defenders do not have any money, and knew that a nonprofit needed to be started. And really, just horrified at what I saw in the medical records. This was when I was still reading medical records just from the hospital, right? Before I even got into the ones from prison and jail, I was seeing how people were being treated when they came into the ER with confusion or with something that was going wrong with their brain, right? But because they were homeless, because they'd been in a fight, because they were a gang member, just because of something that was being judged, they were not getting the treatment that they should have gotten when they were coming into the ER. And that went into these cases from lots of different angles, right? Seeing people die while they were hospitalized because of this type of care, and then seeing someone go to prison because they were involved in that person's injury before they got to the hospital, right? And so then that person is being incarcerated. So this is how Nurses for Social Justice got started. And really, as far as working with judges and attorneys, people that are involved in the law, in deciding what's going to happen to people, really, there are so many ways, right? I was doing these CLEs. Ideally, which is always how I come at things, is like ideally, and then I realize we're gonna have to chop it down from there. Judges, in my opinion, they should have an unbiased healthcare provider at all times available to them. They have medical information. They should have someone that they can go to who they know is not caring what side is winning when they go to trial, right? And saying to them, all right, this is what this is. This is what it means if you're incarcerated. This is what it means if you're not incarcerated. And because a disease, right, that you have living on the outside, it's a different disease when you live on the inside. It is when you're incarcerated, the way that you get treatment, the speed at which you get treatment, the food, the stress, the body is different. It is just functioning differently when it's incarcerated. So another part of it is really the expert witness aspect. That it is a business, right? And we know that, and that's utilized sometimes at trial. Oh, you're here, you're a paid expert witness. But like it's a business. And I see the experts taking a stand, and it's my expert versus your expert. I mean, how gorgeous would it be to have attorneys, judges, and experts coming together and discussing what's actually going on, right? And determining, should this person be incarcerated for this long with all of these diseases? Should they be out on parole? Should they get medical release? And they're being, in medicine, there's a team of people that are taking care of you. And really, there should be this holistic team when these decisions are being made, because these decisions are life altering, sometimes life ending, right? All of the things that happen to someone when they're incarcerated. So I think that there's just so many ways. I was just at this NACDL conference. It was a forensics conference, and the amount of information that was given just by nurses at that conference to help criminal defense attorneys understand sexual assault, injuries and sexual assault, injuries and strangulation, which is now this felony all across the country, right? And the medical information that we have about strangulation and sex assault, some of it is really old and really wrong. Same with the history of shaken baby and bite marks and all of this forensic information that is just being passed on and on and on and on for years and years and years, and not being confronted that things are different, that was not true, that we have more science, that it has changed. So I know that those are really, really idealist kind of ideas, but
No, that's what we need though, Jen.
Yeah.
I think we need to be shooting for
Shooting for the stars.
the stars because there's so much work to be done. And
Yeah.
I think you kind of highlighted some really great suggestions around what can be done moving forward in terms of education both ways, information sharing between legal practitioners and medical professionals. And I know, Eloise, if you want to move to our last question, because
Yeah.
we're trying to get to
Oh,
what
sorry.
other recommendations. No, and not to rush you, but just so we can get to our last question.
No, thanks, Caitlin, and thank you so much, Jen. You sort of inadvertently answered what I want to pose to our other two panelists, which is more specific, concrete suggestions for how to improve medical care and specifically improvements to the systems in which clients are moving through. So, Dr. Herdman, I'd like to just pose this question: what sort of like advice or feedback might you have for judges in particular when incorporating healthcare provision and sort of overcoming associated challenges in their decision-making process, and just, you know, something they would like to say to judges to help their general understanding of how healthcare can be improved in the corrections landscape? I know that's both broad and specific, but
that's all right. Well, I think that we would welcome, first off, I love it when a judge calls and asks for something, because we often don't know what's being presented. We don't know what's being presented in the courtroom. And the patient may say something in the courtroom that they're not willing to say in the jail and we need to know that if there's a service that they're not getting, or if they are getting the service and they told the judge otherwise, we would like the opportunity to, let the judge know as well. But we have a few judges in Philadelphia that call routinely to say, oh, can you get this person on MAT, for example? Or can you give me a sense of when their XYZ treatment will be complete? Because I hate to say this, but maybe I won't release them until their treatment is complete because they won't get it since they're homeless. And we're happy to coordinate and do that. So the other thing is any judge that comes out here and takes a quick tour, give me an hour, and then I think they'll know a lot more about what they can ask for, since they would have a better understanding of the services that we offer. And if they're seeing things that we're not doing, then because you give them a tour and they say, oh, you don't provide XYZ, well, then we better take a look at whether we can do that. So, that kind of exchange is the primary thing that I would say would improve the coordination of services for patients.
Okay, and thank you so much for that suggestion. We'd love to hear from you, Dr. Rice, but really quick, we just want to flag for the audience that this is your last opportunity to ask any questions to our panelists before we start wrapping up, because we are low on time. So I just wanted to flag that quickly. But Dr. Rice, would really like to hear from you, if you could directly address the population of judges when it comes to a public health framework and specific improvements to the systems that could be made. What would you say?
I kind of like to think about giving advice in threes, but I think I've ended up with 4 here. So apologies on the overextension here. But I think one of the real primary goals of the work of public health right now is to really address health equity and to address health disparities. And we cannot do that. We cannot provide that mission of making sure that we all sort of are able to live our best, most fulfilled lives without coordination and collaboration around this issue of mass incarceration and how we deal with communities who are incarcerated. And so I think my first takeaway would be to, it's sort of a build on Dr. Herdman's recommendation, is really about being more collaborative in thinking about not only alternatives to incarceration. I recognize that public health often does not come to the court system, and the courts don't often come to the public health system, and yet and still we rely on the tools and the services provided by those systems, yet are typically unfamiliar with what happens in those environments. And so in the places where alternatives exist, and I would say that they exist in many cities, in many counties, in many states, in many jurisdictions, and they often go underutilized. And so I would say, I would highly recommend that judges reach out to public health directors and find out what services, what healthcare services, physical healthcare services, what mental health services and what social services are offered and available in their communities to both divert people from entering the system, but also to introduce them or connect them to when they are in community. And so that would be sort of my first piece of advice. As a former public health practitioner in community, I would say we would relish the moment to be able to say, we have this mental health program that would better serve this client rather than sending them to jail, or someone who can't afford to post their bond and will languish in an institution. We would like to connect them to this care. And I recognize that, again, public health practitioners typically know what services are offered in their community and can typically make those connections at that higher level. And they can also make sure that those programs and services are evidence-based and can actually provide the services intended, because the work that we're doing is focused. I mean, it's a serious scientific discipline that ensures that we are connecting folks to programs that work, that have evaluations that show that they've been successful. So my second piece of advice would be to think about ways in which there can be more data sharing, because again, it's often very challenging for us to tell the collective story of our community without having access to information. And so I think the more that jail providers, prison healthcare providers are more open to sharing their data about what's happening inside those facilities with both the folks who are on the judiciary as well as folks in the public health community, the more we have that expectation of data sharing, the more we will be able to, one, know what's happening behind bars, to be able to then potentially prevent the damage that's being caused, provide alternatives to those. And really, essentially, the better we are able to evaluate the success of programming that we're potentially sentencing people to. So that would be sort of my second piece, or my second takeaway. My third piece of advice, I think, is for there to be some collective conversation around accreditation and standardization of services that are provided in facilities. So there's an organization called the National Commission of Correctional Healthcare, which is just one organization that provides accreditation to jails, prisons, and juvenile detention facilities, specifically on the healthcare and mental health care services that are provided to people who are incarcerated. But accreditation is not mandatory. And so for facilities who typically, and it's an expensive undertaking. So it really requires collaboration and an intentionality by leadership, who typically tends to be local sheriffs, right? Or folks who don't have medical or public health training, who are making the decisions about whether accreditation happens or not. And so there are ways in which that judges can be involved in setting mandates for, or ensuring that facilities and institutions are doing their due diligence to ensure that they're providing best practice and what we would say community levels of care. And so I think that those are sort of three ideas that would probably be appropriate of which judges can have some input in and insight into helping to provide the best care. And so here's my fourth thing, is that in public health, we often do not, we never recommend developing interventions for communities that you have never been in. And so what I would say to you is, if you have never been in a jail and seen the type of care that happens, if you've never been in a prison and seen how care is delivered, because they are different as delivered in both jails and in prisons and even in juvenile detention facilities, I would highly recommend a visit, because I think that having the firsthand experience of seeing what people are experiencing will help give great clarity and perspective, and probably would give a lot more intentionality to thinking about the ways in which we can do it better. We deserve a better, more robust and just system for all of us. So that would be those would be my four pieces of recommendation for judges.
Wow, thank you so much, Dr. Rice. And yeah, we're just very grateful to hear sort of your more holistic perspective, again, on how we can move forward. And, I think individuals within different spaces often feel helpless when trying to apply their expertise to something they have no expertise in. And I think that's, something that you pulled out for us, is just that there can be a situation where everyone is doing their job and pulling from expertise, from other fields, de-siloing that you mentioned. And, so everyone can do their job and not step on each other's toes, but actually feel supported and feel enriched and informed by, these different systems. So we are reaching our, our stopping time, but if there's anything else that either of you would like to say, I know Dr. Herdman had to leave right on the dot, but any last comments or impressions or observations, suggestions before we bring this to a close?
I would like to offer to all judges across the country to have, nurses from social justice come speak to them about what we know about healthcare and the healthcare system, and give them, our not just our basic ideas, but some of the forensic nurses, and all for free. Just come have us over. We'll come chat with you and get you the information that you need.
Great. Well, thank you both so much. We really appreciated your time here. And I just wanted to let our audience know that this information in this panel will be available on demand in recorded video format. If you missed certain parts of the conversation or just would like to return to the more specific, tangible recommendations that our experts gave, which were so enlightening. So with that, we'd just like to thank everyone for attending. Caitlin, is there anything else you'd like to add before we close off?
Yeah, thanks so much, Eloise. I did put this in the chat, but just wanted everyone to know that, like Eloise mentioned, we should have the video recording out to you all within the next 24 hours or so. We'll send that to everyone's email who registered, but please feel free to send and forward or post both the recording of today's discussion, and we'll also be sending a very brief survey so that you all can give us some feedback on the brilliant insights of our panelists, but also some other topics that you all might be interested in learning more about. We would really love to kind of continue this conversation and have our two experts and Dr. Herdman, who joined us today, but then also invite other folks in the field. And Dr. Rice, I don't know if you mentioned this, but I really love that when we were speaking during prep, you talked about the idea and the term of a pracademic, a practicing academic. And I think, certainly as a former public defender, I know, and I'll echo what you've said, Jen, that there is so much for legal practitioners, including prosecutors, defenders, caseworkers, judges, to learn from medical and health experts. And I think it can be a two-way learning opportunity. So we would love, to be able to facilitate those conversations so that we're learning from the healthcare and public health experts to do all of our individual jobs better, and to really have a more holistic and a response that takes into the individual person as a whole. And so really just so grateful for your time today, both to our attendees and our wonderful panelists. And thanks everybody for joining. We hope to be in touch with you all soon.
Thank you.
Thanks, everyone.
Take care.